Hello, my name is Rajeev Attam. I'm an assistant professor in gastroenterology at the University of Minnesota, Minneapolis. On behalf of all the authors of our article titled EUS-Assisted Fluoroscopically Guided Gastrostomy Tube Placement in Patients with Roux-en-Y Gastric Bypass Surgery, I thank GI Endoscopy for giving us this wonderful opportunity to present our work. As you know, Roux-en-Y gastric bypass is the most common bariatric surgery performed in the United States. Every year, about 120,000 of such procedures are performed. Although very effective at weight loss, these procedures do make access to the remnant stomach difficult. The remnant stomach may need to be accessed for the purposes of nutrition by placement of gastrostomy tube or for endoscopy such as ERCP. The current available techniques to access the remnant stomach include G-tube placement by interventional radiology using ultrasound or CT guidance, deep enteroscopy like single balloon enteroscopy, double balloon enteroscopy, or spirus over tube enteroscopy, and surgical G-tube placement. All these techniques are limited by technical complexity, invasiveness, and complications. A radiographically placed G-tube may have to traverse other hollow viscera to access the gastric remnant. This procedure carries about a 25% risk of complications. Also, a non-distended gastric remnant surrounded by loops of small bowel and colon may pose challenge to even the most experienced interventional radiologist. Deep enteroscopy, including single balloon enteroscopy, double balloon enteroscopy, and spirus over tube enteroscopy, is successful in reaching gastric remnant in about 2/3 of patients. Also, when enteroscopy is performed for ERCP rather than for G-tube placement, it becomes an extremely tedious procedure, severely limited by a forward-viewing endoscope and lack of adequate accessories. Laparoscopy and laparotomy can safely and effectively gain access to the remnant stomach. However, these procedures carry the inherent risk of any surgical procedure and are difficult to be performed in patients with history of multiple previous surgeries and dense intra-abdominal adhesions. These obstacles led us to develop our technique of EUS-assisted fluoroscopically guided gastrostomy tube placement in patients with Roux-en-Y gastric bypass surgery. The technique combines minimal invasive surgical techniques with therapeutic endoscopy. It involves identification, puncture, and insufflation of gastric remnant using EUS to facilitate a fluoroscopically guided G-tube placement. In this article, we present a series of 10 patients who underwent gastrostomy tube placement using this technique at the University of Minnesota Medical Center Hospital for the last 1 year. The procedure was performed by a team of minimal invasive surgeon and a therapeutic endoscopist. I thank you for your attention.